Hi, all. We'll get started now. Welcome to another X Space hosted by Democrats for an Informed Approach to Gender. I'm Ellie, DIAG's Executive Director. DIAG is a 501c3 nonprofit organization of lifelong Democratic voters. We're working to shed the light on the harms caused by gender ideology, the erosion of women's rights, and the medical scandal of so-called gender-affirming care. Our goal is to shift the narrative among fellow liberals. To learn more about Democrats for an Informed Approach to Gender, please visit our website at diag.org. That's di-ag.org. While you're there, check out our merch store. And if you'd like to help expand the work we're doing, please hit the donate button. Today, we're going to take a close look at a medical intervention that clinicians are prescribing for the growing number of males who want to present as female. Our three guests just published a paper on the psychological and physical effects of exogenous estrogen on males. Their new paper appears in the journal Discover Mental Health, a Springer Nature publication. Joining us is Dr. Lauren Schwartz, a board-certified psychiatrist in private practice in Oklahoma City. We also welcome Dr. Carrie Mendoza, an emergency room physician in Chicago. And we have M. Lal, a researcher and writer who focuses on gender medicine. ML, as we call him, is also a member of the DIAG team. Welcome to you all. So let me start with you, ML. Your paper is titled Emerging and Accumulating Safety Signals for the Use of Estrogen Among Transgender Women. What are safety signals?
Hi, can you hear me?
Yep.
All right. Well, thanks for having us here. Well, a safety signal is medical terminology for information that suggests a potential causal association between a medical intervention, like a drug, and an adverse event, that is, an outcome that is not beneficial. These signals are the first step in pharmacovigilance, which is how we monitor the safety of drugs after they enter the market. A safety signal isn't definitive proof of harm. Instead, it's a red flag that warrants further investigation. These signals can come from various sources: case reports of rare events, observational studies showing higher rates of a disease in a treated group, or even animal studies. So our paper is a compilation of over 50 plus such studies that have reported these safety signals, all from existing medical literature, and all pointing to a concerning pattern of harm associated with administering estrogen to males. It's a review. In other words, we have not conducted any new research. Instead, we compiled the existing studies that mention these safety signals and reported the findings accurately without any sensationalization. There are several tables for easy review, and the goal is that having them listed in one review makes sure that the clinicians are aware of them so that they report the adverse events faithfully. They also form the basis of proper informed consent. And the last thing I want to add is that this is not to borrow a term from Dr. Cass, an exceptionalized process. It is something that happens naturally, commonsensically all the time. For example, if you take the drug thalidomide in the 1950s, it was marketed as a sedative and to treat morning sickness. But then after some time, a few doctors started noticing a sudden spike in a very rare and specific birth defect among newborns. And the first sign wasn't a large trial. It was a handful of case reports. Could doctors say at that point of time that the birth defects among newborns were because of thalidomide? No, but it was an important safety signal. And because the event was so rare in the general population, that those few cases that were happening among those newborns were a powerful enough signal to trigger an investigation that went on to uncover a global tragedy. And that's the role of a safety signal, to force us to be cautious and to look for more errors in the treated group and investigate them rapidly, not to wait for absolute proof while more people are potentially harmed.
Okay, and the general process for, when safety signals are kind of, when someone's alerted to them, what's the process like Is there a specific process for dealing with safety signals?
Well, the first thing that should happen is that there should be vigilance. I mean, uh, whether it's clinicians, they should be aware that these are the things that are happening. They should be asking the patients as to what are going on in their lives, and they should be able to record it. And there are national databases in the United States. We have
Okay,
the FAIRS database, for example, and then there are national databases everywhere else, and uh, these get recorded there. So whenever
got it.
an adverse event
Yeah,
gets reported and it seems suspicious and seems to be associated with that intervention, that's where um, you know that's when you record it. It's not absolute proof, but it essentially tells us that this is something to be concerned about, and if any other event like this happens, because it is rare and it's not happening so much in the general population, uh, you should be recording that. Yeah.
got it. Great. So your paper, we'll stick with ML. Your paper was a review of existing medical literature.
Mhm.
And did the studies you included convincingly show causation? Could you say that estrogen was the cause of these um, safety signals? You note that some of the studies did not provide information about duration of use. Um, so, how definitive are these studies?
That's a critical question that gets to the heart of how we evaluate harm. For the vast majority of these signals, the studies show associations and sometimes strong associations, but not definitive causation. And incidentally, on this question of causation, if I can, I can set something right. The same is true for the other side of the ledger. The low quality studies that purport to show benefits are also showing associations, not causation. But back to your question. You cannot. You really it's unethical and impractical to design a study, a clinical study like a randomized control trial that could prove causation for a harmful outcome. I mean, think about it. If a researcher thinks that there is something which is uh, toxic, and if you're a researcher and you believe a substance might be toxic or harmful, you can, for example, ethically give it to a group of people a substance that you suspect is toxic just to prove it. 3 months down the line, oh, the treated group has become worse. Wonderful. That shows causation. Um, and this gets to the heart of the nature of evidence of harm. We rely on the accumulation of these signals from different types of studies, whether it's observational data, case reports, case cohort studies. And when you have dozens of studies from different researchers in different countries, all pointing to the same types of harm, whether it's cardiovascular, oncological, neurological, the signal becomes progressively stronger over time and demands our attention. And the lack of, as you're saying, like duration, perfect data on things like duration doesn't invalidate the signal. It highlights the urgent need for better, more systematic long-term research to make sure that these signals are not spurious.
Okay, and I assume that goes. How does that work on the opposite end, where you have supposed benefit? Is it still considered? Um, i- is it so the same kind of doubt should be raised by something that shows benefit without, but it wouldn't be causation; it would be association,
I mean,
as you're.
it is. I mean, difficult to always show causation. In fact, often we do not know why an intervention actually works. I mean, there are theories around it, um, but what I should point out that the yardstick for a benefit is always higher. I mean, if you're going to intervene on the human body, um, the yardstick has to be higher because as experienced medical professionals know, and this is the case for any research for that matter, any researcher understands that when you make a statement about when you make a hypothesis, you often cannot and you're very and you're very enthusiastic about it. Often what happens that you tell the world about it and the world comes back and tells you, no, that's not how it that's not how it is. And that's an essential part of knowledge creation, this humility, that you suggest something and then the empirical data comes and says that this is not the case. So when you talk about a benefit, that benefit uh, should be something that actually does. I mean, there should be some very strong evidence that it does something. The null should be that it does not work, if that makes.
Yeah, makes sense. Yeah, absolutely. We're going to move to Dr. Schwartz. What was the impetus to write this paper? Why did you and your co-authors decide to undertake this project?
Sure. Well, first, I really appreciate you having us here to discuss our paper. And so, to address your first question, we decided to write our paper because we saw the significant growing gap. I think between the public and clinical narrative surrounding these types of interventions, kind of under the umbrella of the gender affirming model, and the actual scientific evidence, which is what we use every day in clinical practice. So the narrative was that these treatments were safe, they were beneficial, we were hearing necessary medically and life saving. Yet, just as clinicians, and as researchers, we were seeing this accumulating body of evidence that was truly pointing to serious life altering harms. And I think for me, I mean, I use these studies every day in practice to be able to talk with my patients about risks, about possible side effects to watch for. It doesn't mean every patient's going to experience every side effect, but I have to have those conversations with a patient so that they can be aware of what to look for if they're starting something. And there was no single resource that was compiled. It was very difficult to find, even a study here or a study there about some of the harm signals. And so, truly, our goal was to synthesize the existing evidence. And what we found was there were over 50 peer-reviewed published studies. So all of these studies were available before to everyone, whether they were practicing gender affirming care or they were not. They were available to everybody this whole time, but we wanted to put them together to be a comprehensive resource for clinicians like myself, for patients, for families, so that truly we could reach informed consent if needed, but I think also recognize the harm that these can cause over time. Our one of our primary foundations in medicine is first do no harm. And we have to look at an honest and complete accounting of the risks.
So, do you see patients? I assume you don't prescribe uh, hormones, but do you see patients that are on exogenous hormones?
Absolutely. And you're correct. I'm not an endocrinologist. I don't prescribe hormones to patients, but of course, I see in private practice, I see patients struggling with all kinds of distress, whether it's related to gender or not. Maybe it's anxiety, maybe it's depression, maybe they're going through something in life. And so, the psychotherapeutic approach, as well as the psychopharmacologic approach, it involves everything that a patient is taking, or has taken, or will take, or is considering. So, absolutely, I've seen individuals that either are currently on or have been on or are considering.
And so you've compiled this information in a paper. I mean, how often is this? You get the feeling that clinicians are extremely busy and they have very little time with patients. How reasonable is it to expect clinicians to have these studies at their fingertips or even know that they exist? Is this just part of the job?
Oh, absolutely. It's part of the job. So if you're going to consider treating a patient with any medication or exogenous hormone, it is your job to understand the risks and benefits. And to your point, no, we can't go and do our own randomized controlled trials. We can't go and do research ourselves because we are seeing patients every day in clinic, and so we depend heavily on studies. Peer-reviewed studies um, are foundational to our practice to be able to accurately communicate with our patients about risks and benefits. That's what we lean on. And so when it was difficult for me to just, to do a search that I would normally do for any medication I would be considering, or even if it's, let's say, a patient comes in and they have cardiac issues and they're on medications for that, and I need to do a search of interactions, it was very difficult to find. And so that's why we did this. Our hope was that now, if a clinician has been struggling to find those studies, maybe it's a case study, maybe it's a small a trial that had several really concerning harm signals, we put them together so that they can find them in one place. And we hope that that can help guide treatment moving forward, because ultimately our goal is to provide the best possible treatment for every single patient, and we've got to understand safety and efficacy.
And so I want to get back to that point a little
Sure.
later about communication with patients. But so you're a
Mhm.
psychiatrist. In doing this research, what did you conclude about the mental health effects of exogenous estrogen on males? Does this help alleviate gender dysphoria? Is that even the goal of exogenous hormones?
Well, so that's a truly, I think, complex question when you look at our review of the literature, and certainly other studies that have been advertised as high quality by proponents of gender medicine. Our review shows a profound lack of evidence for the intended psychosocial benefits of estrogen for males. So even the highest quality studies that are out there that we found don't find any psychosocial benefit in males on cross-sex hormones. One of the largest studies in New England Journal of Medicine in 2023, it found no psychosocial improvement in males. So, when we look at even the most robust studies that have been presented by supporters of this, when you look at proper analysis of them, um, and there you disaggregate just by sex, estrogen use was actually associated with a higher probability of planning suicide, attempting suicide, being hospitalized for suicide. So this promise that this particular intervention actually alleviates depression, anxiety, or dysphoria in males, it's truly not supported by any evidence that we could find.
If I could add something here. This is really interesting, and that
Okay.
kind of interests me
Yeah,
as a researcher. But
absolutely.
there's a 2020. Sorry, can you hear me?
Yeah, we can hear you.
Okay, so there's a 2020 Cochrane review, which and Cochrane reviews are highly regarded because they are considered the gold standard of systematic reviews in healthcare, and they're developed with rigorous, transparent methodologies. So there's this 2020 Cochrane review called very simply anti-androgen or estradiol treatment, or both, during hormone therapy in transitioning transgender women. And they tried to answer the question very simply: does hormone therapy help transgender women undergoing gender reassignment to transition? I'm just quoting from the paper. And they looked at nearly 800 studies. And in the end, they were, and I quote again, unable to find any relevant completed studies that we could include. So this was the end of 2019. So if you're looking for new studies, they should be 2020 and beyond. And the best, we don't have any Cochrane reviews after that 2020 study, but we probably have something what the proponents of medicalization would consider even better evidence. The recent Yale Law report by McNamara and others, which criticized the CAS review, and they flagged the 7 best available studies, which apparently showed psychosocial benefits uh, after hormone therapy. 2 of them in the main text, 5 of them in the appendix. One of the two was the New England Journal of Medicine study. which the Yale report said was the longest and largest study to date on gender affirming medical treatments in youth. And that had a paragraph that said that they could not find any evidence for benefit among males. It was not mentioned in the abstract, it was not mentioned in the conclusion, but it's there in the main paper. And then they mentioned the Tordov paper, which is so bad that, I think it was the physicist Wolfgang Pauli who said, it's not even wrong, so it falls in that category. And then there are 5 other studies that they mentioned, and none of them talk about the effects on males, separately. And except one, which was, I think, had 14 subjects, and they evaluated after 3 months. So that's not even, should not be even considered a study, so to say. So yeah, there is limited, as the systematic reviews show, there's limited evidence for benefits. But it is even more clear when we look at the benefits for males on cross-sex hormone.
Okay, so we're not seeing evidence of benefit for the on the psychological psychiatric side. It sounds like.
Exactly.
What what's let me ask Dr. Mendoza about the physical effects. Obviously fertility is affected, although, do we even know to what degree that's true?
Hi. Well, first, I want to echo what my colleagues are saying and just thank you for hosting this space, and thanks to Lauren and ML and others who worked on the paper. And just before I kind of dive into that, I just wanted to make sure to sort of remind people that there's a lot of information already known about estrogen related to you work around menopause and the treatment for that. And so again, the goal with kind of collating a lot of this information related to treating trans identified men was to really bring it all together so it's easy at people's fingertips. But people do have to realize that there is a lot known about estrogen in general from our experience, and adverse effects that occur in the whole world of trying to address menopausal symptoms. And then just also to remind folks, there's just general practice principles, as Lauren was saying, but in my extra training in medical toxicology, the general principle is that every medicine can be toxic. It just depends on the dose, and other factors such as other medicines people are on or other underlying conditions they might have. So I just want to kind of frame it that it's not that these things are just taken in isolation. They're taken by living humans who have maybe on a host of other medicines and also may have a host of other underlying conditions that the estrogen, makes worse. So, and just lastly, on the sort of broad overview is just, and ML and Lauren both were getting at this, is really principal medicine is, what's the diagnosis? What are you treating? And then, what are your endpoints to say I successfully treated this patient, or there's adverse effects that require that we stop the treatment. And I think that gets again lost in the broader politicized conversation. And so again, the paper is hoping to really bring this back into the fact that we're treating human beings and we don't want people to be harmed. But in terms of the more specific effects on the body, as you were mentioning, the issue around fertility, obviously, that is something that is known that it can really affect men's fertility when they take estrogen. And that's obviously, very, very devastating, you know, s- especially, for young men who, may change their mind down the road and, want to have children. So that is, a very big issue. And then the other, very high level things that are really known with estrogens, cardiovascular issues, DVTs, deep vein thromboses, MIs, heart attacks, strokes, And then, of course, it was touched on the mental health issues. There's really, quite a bit of, uh, evidence around the fact that this can worsen depression. And then concerns now around really dementia as we have an aging population and we're understanding more, you know, looking out for more risk factors for early dementia. We certainly don't want to be causing iatrogenic, meaning, induced by the medical system harm, um, decreased mortality, the series of things in the paper that were outlined, very well, the pancreatitis, diabetes, and then, it did cancers. And when I was working on the WPATH files, there was, the WPATH folks really had entries and discussions where they knew there were cancer risks. Yes, I mean, some things related to testosterone, which is not our topic tonight, but just in, they were even admitting that, these high doses and sort of unknown doses that people are taking to titrate, I think, physical effects are cancer risks. And so with this, there's concerns around thyroid cancer, testicular cancer, breast cancer. So again, the importance of this paper is, hey, do we need the medical community needs to really dial in on cancer prevention for people who may be taking, men who are taking doses of estrogen. And so we wanted to bring that, we want to bring that to light because we don't want people to be harmed.
So I'm going to back up just a little bit. You talked about some of the cardiovascular risks, and you mentioned DVT, deep vein thrombosis. Can you just, that's a term I've seen come up again and again. Can you just tell us what exactly that is and why it's dangerous or a problem?
Sure. Well, it's basically just clotting happens in your deep veins, which deep means more central in your body, that basically has closer access to flick off and go into your lungs. And the one of the main risks with DVTs relates to the sequelae of a pulmonary embolus because you can have a cardiac arrest from that. There are unusual cases where the DVT itself is so large that it actually, cuts off the blood flow to the limb and becomes a limb threat. But that's less common, but I have seen that over the years. Risk of the pulmonary embolus, which it can be devastating. It's on differential when people come in cardiac arrest. Is it because we would give clotbuster medicine to try and break it up. So there's high mortality. Just the overall category of like estrogens and progesterone to
Yep.
learn in emergency medicine. So like the typical thing, the woman who smokes cigarettes and is on birth control, and she's got leg pain or chest pain, a DVT and a P is in the differential. So again, because my job in the emergency department is to make sure that I'm addressing the life threats. Obviously, there's a lot of those are the thing that I have to make sure I do not miss. Um, and so yeah, with that DVT risk, it is you concerning, and I do think that it's not something that is as much on the radar. I think in general with in emergency, and it is whole medical population where if a trans-identified man shows up at a care office, and may have, leg pain, and maybe some swelling, you know, um, I would hope they would get for no sound study, or if there isn't such thing, but in the differential, the with G, be estrogens, this could be a blood clot, or if they showed up with chest, this could be a pulmonary embolus.
I see. Um, just so you know, Dr. Mendoza, you're a little spotty, your reception. I don't know if
Oh,
you
I'm
can
sorry. Let me see if I
change a little bit.
can. Yeah, I let me see if I can remedy that.
Okay. So and I don't know if you can speak to this while you're juggling around your phone, but are these effects that we're seeing in men, are those paralleled in female estrogen or just estrogen in women?
I think we're
And
losing you a little bit too. You're kind of cutting in and out. Sorry, I couldn't hear the question either.
oh, no,
Yeah,
boy.
I couldn't hear it. I thought maybe it was me and my bad connection. Yeah, I couldn't. I maybe you could rephrase. I couldn't. It didn't come in clearly.
All of us. So the question is, are these parallel effects to what we see in women? Like, can you look at data of estrogen effects of exogenous estrogen for women, maybe, for perimenopause or menopause, and extrapolate that to what you're seeing in males, or is this a completely different profile?
Um, I think it's a little bit of both. Obviously, there's a large body of literature around menopause hormone replacement learnings from that. And so, of course, it's logical to make some, extrapolate it. And as has already been said on this conversation, there's a lot of medical practice. Most of medical practice is based on, observational studies and FDA approved things, and not everything is randomized controlled trials. So I think that there's a reasonable extrapolation. I think there's also very, very reasonable rational um, uh, sort of being true about the fact that there's a lot that we don't know. Because obviously not that we've ever had in a time so many men on estrogen, and also not tracked as to the dose, not followed in terms of their adverse effect, and not clearly reported at a very, mandatory reporting at a granular level on top of, all the politicization. And so, and as also was said is, we really, it's like, first do no harm. And so, it really is an approach of saying, wait a second, what are we treating here? We're treating in the young under 18s and young adults, we're treating what we're told is depression related to the fact that they're not in alignment with who they think they are. So we're basically using it as an antidepressant. And we all know, most people on this, I'm assuming, has already been discussed, that there's really no evidence around that. I mean, obviously people who are, religious based, or, may just have a lot of different life experiences would just say, well, it's just unethical. And that's just not even a thing that's real. So why applying sort of scientism to basically prove something that is not real is sort of unethical in and of itself. But in America, in American medicine, it's very libertarian, and the cart is before the horse on a lot of things. I saw that in the opioid crisis, opioid epidemic. I've seen it with a quote unquote medical marijuana, where just use of different things that was tethered, but the train legal with claims about all kinds of things from depression to like you're rich, were made to, and it was all not true. So I guess what I'm saying is that, it's very difficult in the way the American medicine is, it's industrial complex, so to speak, is hardwired, that it sort of gets outside of even where is the evidence. It's sort of something takes off, as we know this all has. And then we're playing catch up here to say, wait a second, look at all these people being harmed. Look at all these things that we already know. Let's rope this back in here, because we know a lot about estrogens, and we know that, giving it to men is not a natural thing. So of course there's going to be side effects. We also know people are on so many more medicines, and so we don't even discuss the fact of how does the estrogen interact with an antidepressant, or you somebody's diabetes meds, or the weight loss meds that everyone's on now. There's just a myriad of things that are just sort of tossed aside, um in with the thesis that had been developed that this makes people happier. So I'll pause there.
Okay.
Yeah,
Yeah.
and
So,
okay.
I'm sorry. Go
Oh,
ahead.
I was just going to jump in just to add to what Dr. Mendoza was saying. I think, one of the important things to realize in medicine always is we have to know when to say we actually don't know. We don't have good outcome studies to look at definitively in terms of benefit, or in terms of efficacy. However, in terms of harm, we have to be much more cautious. So what we can do is at least extrapolate, what the information that we do have, when other patient populations are treated with, let's say, exogenous estrogen, for example. We can take what we know occurs in other populations and apply that. The other pieces, a lot of these patients are on like super physiologic doses of estrogen. These are not doses of estrogen that a natal male's body would ever experience naturally. And so, at such an increased dose, we absolutely must be talking about harm signals. As Carrie said, if there's something that's, if there's someone's having shortness of breath or chest pain or leg pain and redness and swelling, we've got to be able to at least talk with them about risks, or we're not doing our job, and we're putting the patient in danger. And so I think that idea of, you'll hear us often talk about, well, we can't extrapolate out always about benefits because you have to be very definitive on that. On harms, it's the opposite. You have to be so cautious until you have those answers, if that makes sense.
Yeah,
And
it absolutely makes sense.
sorry,
Go ahead. Yeah, go
if
ahead,
I could
Mel.
add something here, it happened recently after our review got published. A parent, we talked, and they said that their trans-identified male child, who has been on estrogen for some time, started to have vision problems. This was a few months back. And the doctor who saw the child, I believe they went to the emergency room, said that this was stress related. Okay, that was the doctor's diagnosis. The discussion of estrogen being administered never came up. Um, but the fact is that there is at least one published case study of retinal vein occlusion in a trans identified male, where the authors concluded that, and I quote, estrogen increases cardiovascular risk when used in hormone replacement therapy. And RVO, that's retinal vein occlusion, is a complication that must be taken into account, especially in transgender women who are more at risk. So here's a case study that existed already, but this the fact that this existed never made it to the top of the consciousness of that doctor. Um, and having that information at the fingertips is something that would helping any attending physician in the future to take that possibility into consideration.
Got it. Yeah. Yeah. Yes. And I'm going to go back to something that maybe it was Carrie mentioned, that was talking about dosages, or maybe it was UML, that the idea of what there's no really good record of what the dosage is. And I think about this cohort, and regardless of what they're prescribed, these are young people who are looking for physical effects. And so, I wouldn't be surprised at all if, for example, you had a male who is prescribed estrogen who decides to double the dose because he thinks he'll grow bigger breasts or he'll grow them sooner. These are not, these are teenagers in a lot of cases. So the thought process, or even if that's communicated, that that it doesn't work like that. You don't just up the dose. But I mean, how do we know really what these people are taking?
Yeah, and that's, I mean, that's just, one of the egregious glaring, issues once I got into this, and basically that they're sort of titrating to cosmetic effects and just ignoring the downside. And it was just echoes of what I experienced during the opioid crisis, where it was, mandated the pain scale and then basically treating to the pain scale. And so the tragedies of, tolerance, overdoses, polypharmacy, back pain people on 5 different things that would make them sleepy on top of the narcotics. All of that stuff was ignored because it was hardwired to the system that the medical center had to get certain level of scores in order to get reimbursed. And so um, that, led to some interventions, of course, after, years of tragic overdoses and adverse effects that were ignored, but led to interventions related to, pharmacy tracking and tying the prescription writer's license to the amount and going after the pharmacies and a series of things that happened that I think as the policy has is obviously many advances in terms of, in my opinion, safety in this area have occurred since the new administration has come in, but there are certainly a myriad of additional policy reforms that need to be in place, and this is one of them related to prescription drug monitoring because it's not being done. And ironically, the difference now versus what I experienced 20 years ago with opioid issue is that everything's electronic. I have to. It's in Illinois, where I'm in many states, prescription electronic connections between the electronic health record and the pharmacy is now I have to prescribe electronically. So I guess I'm making the point that it would be very easy to put up in place a lot of guardrails that came about from the opioid debacle here because there is not that discipline. And when things have gotten to such an egregious level where we're just ignoring, oh yeah, whatever the dose and let them just, do that. That's what I experienced because I'm on the receiving end in the emergency department of the person in a clinic who just is writing, crazy amounts of opioids for like a teenager who sprained his ankle. I was the one dealing with the like distraught family or the person who overdosed and all of the side effects. The prescribers aren't in the ER with me dealing with the tragedy, the adverse effects and the sequelae. So, I mean, again, that's why I've been committed ways that I can and with this paper. I do think that this discipline with the prescription writing to make sure that these patients aren't being hurt.
Well, and can I also add something to that? Something that we see often is patients are being told when they're prescribed estrogen, for example, that because it's going to help them develop into more closely their true self, that it can't be the hormone that's causing any side effects. That they're told that it's probably something different, but you just need to get used to being your more true self. And that really puts the patient in a position of not knowing what to do. Everybody can have side effects. One, just because you have a side effect to a medication doesn't mean you don't have the distress that we're trying to treat. But beyond that, I think patients and families become fearful that if they go to the prescribing physician or clinic and say, "Well, I'm having these side effects," they're going to get pulled off of something that they've already been told is the thing that is life saving. So there's this very scary inability to talk about any side effects, to talk about any harms, to talk about any, because they fear that if they get pulled off of anything or have to taper down lower, they're gonna kill themselves. That's what they've been told. And so I think that's where this whole idea of medically necessary and life saving is very concerning and truly dangerous because we're presenting it in such a way that just puts patients in a lose-lose situation, and that is on medicine has created that
Yeah.
mess.
Yeah, and that's just such an excellent point, Lauren. And just to piggyback on that, I literally experienced during the opioid crisis. I mean that whole thing where one side in the outpatient clinic they're treating their pain and told that decreasing people's pain can, decrease their depression and their anxiety and have them live a better life. The issue is that it just got out of hand because they exposed people to it because of various things I've already talked about. It's more complex. So they've overexposed people who shouldn't have had it, over created a very loose definition of, chronic pain or intractable pain. Also ignored, somatization, people who were primarily depressed or anxious, but then were having some pain, is very, very difficult. But then treating the pain instead of treating the underlying issue. And then when they come to the ER after something horrible, or they'd run out of the meds and the clinic cut them off, it's like, wait a second, they told me this is life saving. If I don't get this, I can't function. So it's a very, very, you know, toxic brew of treating patients overly aggressively, but not addressing what all that meant, and then sort of leaving, the acute care world to pick up, the pieces, but yet kind of quote unquote being the bad guys, because they would say, hey, wait a second. I'd be like, I'm not prescribing you more, the opioids are your problem. And it's like, the last thing I'll say is, every day I've got at least one or two patients in the ER every shift with cyclic vomiting syndrome, a myriad of issues because of marijuana, and literally no one, of course, the buy side is telling them this will solve every problem, but when they land in ER, no one has told them this can cause gastritis, can cause you to have this intractable vomiting. It can cause a host of other things. No one talks about it with them. That what are the adverse effects? And to what Lauren and now Mel are saying, every medicine, even if there's a therapeutic window, and that's one of the toxicology, principles, and just general medicine principles. There's a therapeutic window, but but you can go outside that window, and you can also be treating the wrong thing with the wrong medicine. Marijuana doesn't like cure every problem. So and people just are unaware of they'll look at me like, like that I'm the problem for telling them that they can't stop vomiting because of the amount of marijuana they're doing every day. So it's very hard, but it doesn't abdicate physicians from knowing the consequences of what they're prescribing and doing, and being aware of the adverse effects, and having those difficult conversations of, yes, you're on this, but you really, if you're starting to develop diabetes, or you're starting to develop, you have 5 risk factors for heart disease, and you're on this other medicine that can cause cardiovascular issues, that's really, really, we need to talk about that, because my job is to inform you of these issues and be a safeguard for your health, even when you might not really want to hear the information. My job isn't to make you happy. My job is to make a diagnosis and, do things safely. In our environment now, being liked as a doctor and getting high, patient experience scores tied to bonuses and things, which should be, illegal in my opinion. So I think is one of the root causes for doctors not being more of, focusing on do no harm, because that might be unpopular with the patient.
Oh, sorry, realized it was muted. So can you just clarify? Were you saying that doctors are telling their patients to um, kind of ignore some of the negative things about estrogen so that they don't, kind of to tolerate it just so that they don't lose this life-saving care, or that they would be at risk if they stop the
So
estrogen?
I think it's not that they're telling them not to stop it. I think when a patient comes to a prescribing physician and they say, "Oh, I think, I feel like my mood is a little bit off," and a physician says back to them, "Well, it's just you getting used to being your true self. This is what it's like to
Uh,
be." Does that make
okay.
sense? Like what it's like to be a woman, but
Yeah.
you've got to get used to that, and or go treat that anxiety or depression. But it can't be the hormone. The hormone. This is because we're giving you the dose that's going to better match you with your true self. And the sad thing is I mean, we know in medicine already hormones can cause all kinds of challenges, from anxiety to depression to sleep disruption, even at very low doses. And so when we're talking about super physiologic doses far above anything we've ever seen anyone on in the past, of course they could cause those problems. And again, it doesn't discount that the patient is struggling with distress related to gender. It just means that, hey, you're experiencing a side effect, and absolutely it could be related. I know this isn't a conversation about testosterone and natal females, but that it can create huge mood disruption. And there's all kinds of things that I feel like now patients feel like they can't talk about it. They go seek to treat side effects of the hormones that they're on and put on, and a lot of times they it creates a situation where they don't get to the root of the problem. If someone has anxiety or depression intrinsically, and let's say the hormone is exacerbating it, we've got to take a look at that, and help the patient, and it can affect everybody differently.
So, two things. I want to go back, this idea that, well, now, these drug registries, so you could track, that was probably a lot put in place because of the opioid epidemic. But, they're, I mean, in California, certainly they're moving to take hormones off of those registries so that they cannot be tracked. So, purposely, so that nobody will know what these patients are getting. And
Which I think is heartbreaking, because at the end of the day, physicians utilizing the tracking systems, we're not doing it to punish or pull medicines away from patients that need it. It's the idea that we've got to monitor things so that the patient, we can communicate safety and efficacy, and we can communicate, okay, are you getting it from more than one place? Can we talk with other doctors about it? So those are in place to help us treat patients better. So you have to look at policies then that appear to go completely against that. For what who would it serve to not monitor those things, to not be able to look at, oh gosh, it looks like you're at a much higher dose than we thought you were, no wonder you're experiencing X, Y, and Z. Why don't we decrease it? Oh, it looks like you picked up this prescription last week, it's not time to refill. Let's talk about why. Maybe you're running out early, or something's, it's a matter of guiding the best possible care for each patient. And so it's, you have to look at policies like that and wonder what exactly they're aiming for.
so,
Yeah, I mean,
and then the
oh,
other
sorry,
question
go
about
ahead.
these, kind of the multi-drug effects that are being just ignored pretty completely. Is that is there something is this the exceptionality of gender affirming care or trans identity, or is that problem pervasive in medicine where the clinicians are prescribing but not really looking at the multi-drug effects?
I mean, one thing I would say, certainly physicians must be looking at all medications a patient's on. That's, anytime a patient comes to see me for the first time, we go through every single medication. We talk about challenges they've had with previous medications. Anytime I'm looking at starting a new medication, I have to look at how it interacts with everything they're on, not just psychiatric medicines. I have to look at, are they on cardiac medicines? Are they on anything for, let's say, seizures or sleep or chronic pain? I mean, there's so many safety challenges with drug interactions. And then we have to again look at what we don't know. Okay, we know certainly hormones can interact with other medications at the level that they're being prescribed now. We don't have long-term outcomes. We don't have data to look at, and so now we're trying to extrapolate from other patient cohorts. But absolutely, it is the responsibility of the physician to be reviewing that with the patients and knowing about all of the interactions and risks.
Yeah, and I can
Right,
just
but
say,
we don't
in
know
acute care.
all the
Oh, sorry.
yeah, go ahead.
Yeah, I was just gonna say in acute care medicine, yeah, as Lauren is saying, first of all, that's just like a cornerstone of, you know, ethical, safe practice. But obviously in acute care medicine, medication adverse effects and interactions and are, that's a cause of, I mean, just allergic reactions, as everyone knows for medicines. I mean, those are things I deal with in the ER, but like, again, when I'm prescribing, I mean, the thing is, this is all automated now. It used to not be automated, meaning there's databases that when I go to electronically prescribe something, a lot of adverse cross reaction things pop up. I mean, some of the stuff is not relevant. Um, and it's not a perfect system, but it's right there. And so, with the prescription drug monitoring, the reason why it really was put in place is part of it. I mean, it was, the state's attorneys general sued basically the pharmacies because they were just dealing with like nuisance, like public nuisance of dealing with so many overdoses and all this. It wasn't, sadly from the medical community, although in emergency medicine, there were years of, trying to advocate for like issues because again, we're frontline people dealing, the emergency department's clogged with patients with these issues or also trying to get diverting stuff. But what I saw, I personally, never over prescribed and I would go to battle with patients. Of course, people would complain about me and, I had security take me out to my car at times because people would threaten me. But the most of the time, 99 I mean, my partners and other doctors, they didn't do that. They're exhausted or they don't want to fight the fight or their bonus is tied to the patient experience survey, which I didn't care. I'm never going to do anything unethical. If I get paid less, so what? But that's not what mostly happened, which is why they got out of control. The reason I'm only mentioning that is a prescription drug monitor when at a state level, when I was in Colorado, they put into a law that you had to check it before you prescribed, and there was a digital footprint. And so what I saw is it changed the behavior of my colleagues because they needed I call it digital moral courage to go back to the patient and say, you know what? Quote unquote, the man won't let me prescribe you more. You know what I mean? Instead of what I would do is I just be like, I'm not doing that because XYZ, your life's a mess. You've been here 3 times for an overdose. It looks like you're diverting your medicine, blah, blah, blah. But most doctors wouldn't do that. So they needed the monitoring system to say, you know what, I checked and it looks like, over in Colorado Springs, you just filled, 60 Dilaudid. No one had that visibility before. So to have it with the hormones and testosterone, and it's for benzos and a bunch of other scheduled drugs, I feel it serves a function for physicians who have a hard time, having difficult conversations with patients because hard. And then it does serve the purpose of the DEA can track this and go after people. And so the fact that like a California or Illinois or New York will try and take that away is because they're on their assumption is that you're by not giving people these medicines you're not treating their health. And we have a different our view is that there's no evidence for what they're treating, which is to be happy. And there's a ton of adverse effects. That's why we need to do this. And I personally think the DEA should get involved with our
Yep.
the harm.
Okay, we're losing you a little bit on that one there. Um, so I want to go back to the topic of patient communication. Dr. Schwartz, you started talking about that before, and so the pediatricians and the endocrinologists have this information about the signal harms. So is the patient cohort receptive to these concerns that are raised? Are they capable of seriously considering the implications of these drugs? We saw a bit about this in the WPATH files with clinicians saying that the patient population was they really didn't understand.
Oh, absolutely. And I think what especially with younger patients, when you're talking about um, children, adolescents, young adults, even we know, brain development isn't your prefrontal cortex isn't even fully developed until your mid 20s, or sometimes a little bit later. And knowing that these are huge life altering um, outcomes for example, sterility being one of them, inability to fully develop in a number of ways. Sexual functioning, we see that it does impact, you know, the sexual functioning as an adult. There's so many things that children and adolescents and even young adults, they feel like, okay, in the moment right now, I am okay to let go of all those things. Maybe I haven't experienced it. Maybe I don't want kids. But it's a 12-year-old or a 15-year-old or an 18-year-old or even a 22-year-old. It's next to impossible for them to determine whether or not they're ever going to want to consider having children. And I think it's so then when you try to talk about all of the side effects, all of the possible outcomes, some of them being irreversible, just life altering. You're altering a teenager's course. It's hard for them, I think, to even start to understand it. And developmentally, a lot of times they're not there yet. And then when we look at the data, any of these cross sex hormones that are preceded by puberty blockers, you're talking about guaranteed sterility. And so how can we be talking with these lifelong impacts with children? And to your point, the WPATH files clearly demonstrated that the the developers of the standards of care were very aware of that when they were developing these protocols and these quote unquote guidelines that I don't feel are medical or professional, but yeah.
Yeah, it's a problem. I mean, and I remember early on seeing these, their social media posts, probably on Discord or something, of these boys wanting to know when they were going to start their period, or this kind of a very, very poor understanding of the reality of what they were embarking on. And the physicians seemed to kind of throw up their hands and say, well, they don't get it. I guess that's too bad. There isn't a response that says, we're not doing this because our
Right.
patients cannot comprehend this.
Right. And
That seems to be a big ethical
and
problem.
yes, it's unethical, but beyond that, it's to me, it's criminal, right? What you're doing is
Yeah.
you're proposing a series of treatments that will take away a child's ability to ever have their own children. Some of these surgeries that follow, the cross sex hormones, they won't ever, you know, females, if they decide to have their own children, won't be able to breastfeed. There's just so many of these paths that are cut short far too early, and it's well before any of these patients could even consider what they're giving up. And to be able to kind of laugh that off and say, yeah, but the whole point is just to make the patient happy in the moment. That has not ever been medicine, nor is it now. And to be able to say, okay, if there's a crisis situation, and especially in psychiatry, if a patient is suicidal and we are intervening for safety and stability first, everything else comes to a hard stop. You don't offer up life altering permanent treatments to alter their bodies at a time when they're in such crisis. We slow things down, we work through what's going on. Of course, there's multiple comorbidities. And if you push kids down this path, this gender affirming path, you ignore all of those other things. And unfortunately, they get further down the path. There are very few off ramps. And then as they're further along, they find the anxiety, the depression, the suicidality, it doesn't go away. And it's just devastating.
Yeah, it's the consumer medicine direction, that shift to be about patient satisfaction that doesn't have to do with curing anything or treating anything, um, is obviously a huge problem here. So I want to shift gear a little bit and talk beyond the paper and discuss some of the other consequences of gender ideology's influence on medicine. So, Dr. Mendoza, you've spoken about the folly of allowing patients to report their gender identity instead of their sex on medical forms. We talked about that in our conversation. Can you explain to us what's happening and why this is so dangerous?
Sure. So when I got into this, and sort of looked at the gender identity form within EPIC, which is the EHR I use, and then I'm in practice in Illinois and Wisconsin. But in Illinois, you can basically there was no field for biologic sex, and so someone would say, well, there's legal sex or gender identity, this and that. Like, what's the big deal? Your legal sex on your driver's license says, you're a man if you're presenting as a woman. But we all know enough to know that that's really state dependent. And there was also a lot of movement to sort of fix that. So, like in Illinois, your legal sex does not have to be your biologic sex. So that really raised alarm bells for me because I'm like, oh my gosh, again, safety issues. There could be missed ectopic pregnancies for females who are registered as men, but they're not. There could be missed, again, there's a famous New England journal. Well, I think it's famous New England Journal case report. I think it's 2019, where a trans-identified female shows up and is basically abdominal pain, but the fact that she's pregnant is missed, and she's in preeclampsia, lost the baby. So the idea that you're messing with the accuracy in the record in terms it is very, very dangerous, and again, everything's electronic, so it's all tied to like sort of what they call standard order labs that the nurses do at triage. In the outpatient setting, it's tied to cancer screenings. Like, if you're registered as a male but you're a female, you're not going to get the notice to get your mammogram. I mean, if you're not a person who, is just knows to do that or something. That's just one example. So I was just completely alarmed by that whole thing. I worked on, a white paper, some advocacy around that, and went to Texas and basically got written into a bill in Texas that just passed this session, that in Texas, you have to be registered. Your biologic sex has to be registered in any medical documentation. And again, when I testified, I mean, this is a life-saving thing, especially for trans-identified people, right? But it affects everyone once they start mucking with the record. And so, I mean, the people that testified that were opposed to this, it was just really concerning. And this is why legislation, people say, well, legislators shouldn't be involved in practicing medicine. But when you get to a point where there's people testifying that they don't think their medical record should be accurate because they think doctors are going to do violence to them, or that if people know their true sex, as if like you come in the ER and I wouldn't know like what your biologic sex is, like it's so outside the bounds of the practice of medicine, and that this has gotten hardwired is really, really speaks towards the level at which this has been taken and how dangerous it is. So, um, electronic health records, prescription drug monitoring, all that is a state level action. So different states are going to have different things. I do think it's something that should be an executive order, should be a national. No one should walk into a hospital there that there's not accurate documentation of that. I mean, the years of the safety things that the hospitals have worked on, and to see some of it unwound because of ideology is the reason why there has to be legislation. So is that kind of what you were? Does that get
Yeah,
on me?
just
Okay.
yeah. I mean, how this has, that this is a wider problem, not just it has these wider implications for patient safety. Um, and so I want to talk a little bit about medical schools now and how this is now the doctrine within medical schools that we have a generation of doctors who are that this is not only real but crucial that you treat people as the sex they want to believe they are, or as they'd like to convince everyone, and to do anything otherwise is unethical. And what do
Well,
we
and
do about
Well,
this contingent?
oh yeah.
oh yeah. So
Go ahead, Lauren.
Either one.
sure, yeah, no. One of the things that I was going to speak to is absolutely we did see so much of this ideology infiltrate into academia and academic medicine. My hope is reviews like our paper and other studies will help those that are in training right now have a better understanding. Because at the end of the day, as a provider, as a medical physician, ignorance and even worse, ignoring harm is not ever acceptable, and it's not an acceptable an excuse. It's never an acceptable excuse to continue to harm patients. And so to ignore and including being unaware of 50 plus studies about harm signals is included in that. And so what we see is my own professional association, the American Psychiatric Association, is still platforming a gender affirming psychiatric care textbook. Actually, Carrie and I wrote a letter together that was an open letter with a couple of other of our colleagues. Actually, Miriam Grossman was one of them, and it was a we just asked, how can you promote this when the evidence isn't there? When you're saying statements like puberty blockers are fully reversible and cross sex hormones like estrogen are not known to cause, high risk of harm. So keep going. I mean, that's the type of thing that we've got to continuously fight against so that training can improve. And again, at the end of the day, it's all about patient care improving. So yes, it did infiltrate. My hope is I think there's a lot of med students and residents in training that are aware that yes, these may be quote unquote guidelines from WPATH or otherwise, but hopefully they're seeing that okay, that's not the end of the story, and to provide best possible care for patients regardless of how they identify, we've got to do better.
Yeah, and to just
Um,
piggyback on what Lauren's saying is the issue with the electronic health record is also extremely important. I mean, safety is first, but the second issue is that there's obviously a generation of doctors coming up and nurses and nurse practitioners who, they didn't practice when there was an electronic health record. So they think if it's in the electronic health record, it's real and obviously it's or they don't understand how it could get mucked up and so that's why it has to be like a just a solid guardrail that like you have to in medical record documentation a person's biologic sex has to be documented. That doesn't mean you don't have a field for how they identify or how they want to be, what their name is or pronouns, but the medical reality has to be hardwired. And so to have young doctors thinking that it's okay not to do that is very alarming. So that needs to be fixed. And then I think just how to have the conversation and how to also, I think what's missing, what that I've worked on and understood is there's really a lack of education around the historical, huge historical, ethical lapses that have happened, in the past, going back to, I mean, obviously, I mean, just to start with hormones, when they synthesized them almost 100 years ago, they first were saying to give gay men estrogen because they thought that would cure their gayness. So there's already this abuse. Of course, the Holocaust and the experimentation and Tuskegee experimenting on, so how lobotomies were thought to be, it's like Rosemary Kennedy, from a wealthy family, got a lobotomy, supposedly because she was, I mean, there's a lot of it was sold as a cure. So medical students and all doctors need to learn that the doctors and the medical industry has made mistakes that they thought were something that was real. I mean, obviously, because they were apparently experimenting, but they thought they were doing a kindness. I mean, it sounds crazy to us drilling a hole in one's head, but at the time there weren't psychiatric medicines. I mean, the lobotomies fell out of favor. Technically they're not illegal. They fell out of favor because the phenothiazines were synthesized in the 50s and basically could help some of these agitated symptoms for psychiatric patients. So I guess I just think that that is so missing in medical education. And again, Lauren and I have tried to, work on CME, continuing medical education modules and things, but the associations and the accrediting bodies and all that are really still captured, even with the sort of advances that we've made. But to get your medical license, you should have to do honest, gender related CME. I mean, yeah.
Well, this brings me to the question of, how does something like that get enacted? Because, if you don't have the major medical associations on board and you have this, political problem where some states, California would say no and Alabama would say yes, how does something like that actually even get imposed or enacted or normalized again?
Well, I mean, now, I mean, you can't, you got to get at the credentialing that you could at a national. I mean, I have to do opioid, CME, of course, I laugh. They're about, 20 years late. I mean, so yeah, but you have to, um, the medical schools, the medical centers are really government contractors. It's such at a stage with American medicine that it's really just very highly regulated. And so you really have to have the levers of government, to be honest with you. There are things they could do nationally. And again, I think, I'm hoping that, some of these things that affect the culture of medicine that I think are just so important to help unwind this. I do hope, yeah, if you want your medical license, you have to do, these CME modules, um, that on, gender medicine. Again, opioids, that's a thing now. So I don't know,
Well,
Lauren, if you have
yeah, and just
thoughts.
to add to that, I think one thing that's really important is, and I keep hearing over and over, oh well, we'll just wait because um, there's going to be lawsuits because there's so much harm being done, and I'm not okay with that. And my hope is the medical schools and the residencies aren't either. That as patients are coming back and saying, "I don't feel better, I feel worse, I don't know what to do about this," that we're having honest conversations about the side effects, and none of us at all are denying that there are patients that are in significant distress. But we've got to not only help the patient in the moment, but we also have to keep as many doors open as possible for those children, adolescents, young adults, and have open, honest conversations about them. And we've got to teach our trainees the same. It cannot be about social justice in a clinic in the moment to make someone happy, because when they leave, they have to live the rest of their lives, and you are, as a physician, responsible for understanding what you prescribe and how it affects them now and also for the rest of their lives.
So, this brings up the question about medical ethics. So, ML, I'm going to go to you. Are doctors violating their duty to do no harm by prescribing estrogen for men for cosmetic purposes, given what your paper has shown are the impacts, the physical and psychological impacts? Do we know if they're really informing their patients about the risks?
Um, to answer your questions, yes, I believe in many cases they are. And that is the central ethical challenge that we have, that, what Dr. Mendoza and Dr. Shorts were talking about. The doctor-patient relationship is not a consumer transaction based on caveat emptor or let the buyer beware. Um, the recent HHS report, which has been criminally undercovered in the press, there has a there's a beautiful chapter on ethics, which explains that medicine operates under a fiduciary model of trust. The patient must be able to trust the doctor to use their expertise to act in the patient's best interest. And precisely because there's such a vast asymmetry in knowledge. So when a doctor says something, the patient always takes that. So when a doctor, the expert, prescribes a treatment with a risk profile comparable to smoking, and this is not something that hyperbole. I mean, if you look at the literature, the standardized mortality ratio for long-term administration of estrogen is around 1.8. So roughly speaking, 80% more uh, people will die compared to a similar age, similar age population who are not on the treatment. And if you look at smoking, for example, it was believed to be around 1.7 to 2, and now I think they think it's more in the range of 2 to 3. So it's 70%. It's about 100% to 200% higher. So, so when a treatment with a risk profile, in the same ballpark of smoking and has no proven benefit, they are not when they are prescribing the treatment, they're not acting in the patient's best interest. And when they fail to disclose the full extent of those risks, the strokes, the cancers, most importantly, I mean, the mortality, they're violating the core requirement of informed consent. I mean, and I guess the doctors in the audience will be able to speak about this much better. I don't see informed consent as this form that you sign and you're done. It's an ongoing conversation between the doctor and the patient. And uh, so uh, so I mean, I guess it would have been understandable somewhat when the risk associations were not that evident, but even then it should have been clear that the effects of exogenous estrogen in natal males are different from the effects of estrogenous testosterone in natal females, and it should have been evident right then that the effect should be investigated separately and seen as what they are. But now, after this, and I hope this is our paper is the first. There are other papers that make this information available to to the clinicians. After this, this is this is just not done. This is by continuing to prescribe such a treatment now, when the myriad safety signals of harm are right in front of you, that wouldn't just be a failure of communication. It would be a profound breach of that fiduciary duty that I was talking about, which is the foundation of ethical medical practice.
Sorry, ML, didn't mean to interrupt. Continue on.
No,
Oh,
I mean, yeah, please
okay.
go ahead.
Well, so I know that fiduciary responsibility, but I will tell you that's not the reality of how medicine is practiced. It's based on malpractice principles. And so I just will share again back with the opioid crisis. You would think, wouldn't it be ethical to write, a 22-year-old Dilaudid for her period cramps? Yeah, but how this is parallel is that the government mandated things for hospitals and doctors to get paid. It's not right, but that's what happened. And the same with this. In 2012, in Obamacare, they wrote in that it's a civil rights offense to not to discriminate against anyone for sexual, and they wrote in gender. Yes, it was back and forth political football. So what the orientation for medical centers, it became, this moat of, oh, we can't say no because we're discriminating if we are. So that, I know it's not right, but that's the reality of healthcare in our country. It's not about, obviously it's unethical, but it became about ideology, and that's with the opioids. It became an ideology to treat pain, and ignoring all the carnage around was it was hardwired. Hospitals couldn't get paid unless they got certain pain scores. So yes, it's unethical, but this is, people are fixed on this ideology that it's real, hence why you need legislation. And again, all of this around estrogen and all medications is known. Obviously, doing the paper is super important to bring it to light in this environment, with this lens. But if it's documented in the chart that the doctor went over the risks and the benefits, and the patient accepts those risks and benefits, that stands up medical legally in court. And in the end, it's doctors don't want to get sued. They want to be liked and they don't want to get sued. And so, like, how I document is you know, I told them, I'm not prescribing because here's the 5 reasons why it's a harm and, n you know, unethical. That's how I document. But, most people don't do that, and you have these clinics that this is their money-making endeavor. It's like the ADHD clinics. Well, is it unethical to give a 7-year-old boy who won't sit still in class amphetamines? 100% I think it is. But I know pediatricians that think that this is an abomination, the hormones, but they think giving amphetamines to boys is okay. So I'm just trying to give some context that it's very difficult with our, I just call it like kind of a libertarian consumer healthcare system in America. There's a lot of things that have to do with the consumerism, well as the requirements that the government makes, you know, health centers do. And I do think that, again, as by legislation and things, unfortunately, has to be involved in this area because the incentives the other way are so strong.
Yeah. Well, and can I add to that, Carrie? I think probably
Yeah.
before I got involved in the kind of the gender affirming care model and dealing with legislation, I was very opposed. I think at any time there was a suggestion of medicine being addressed through legislation, it just we medicine and the law don't play well together. They are medicine is always evolving as we learn more about what's best for patients, and sometimes things get misinterpreted or completely flipped and redefined in legislation. But when doctors continue to cause harm to patients, legislators have to get involved. There's really not a choice. And as slow as we look at government processes moving, it just adds to the level of harm done to patients throughout the entire time we're trying to figure out how to get in front of it. So I think one thing that our paper is, it was really important for us to do is we wanted to put a review together that we could put in the hands of patients, that we could put in the hands of parents, of families, of providers, anyone who wanted to look at harm being done, and harms and risks that could be caused by estrogen in natal males. They can, I think, through education of not just trainees, but physicians and also of patients, they can utilize that. And my hope is we reduce harm. Even when legislation and/or medicine is still falling behind, so hopefully this empowers patients to understand better what their options are, and some of the things being promised aren't actually what they are. So my hope is this can offer a better path forward for everyone. And I know it's the beginning. We've got a lot of work to do ahead of us, but at the end of the day, I mean, these are human beings, and they have their whole lives ahead of them, and they deserve to be treated with respect and dignity, but also they deserve excellent medical care.
So this is going to segue into my last question, which is, how do you see the paper being used? You mentioned parents and patients and clinicians using it, but the clinical community has largely rejected this kind of information. They've rejected CAS and the HHS evidence reviews. You know, is do we s- is there an understanding or a belief that the tide is turning on the reality of this medical model? Um, Given the Supreme Court upholding the ban in Tennessee, and also what we're seeing in the mainstream press more and
Mhm.
more. Do you expect the clinicians will now be willing to look at the question of, are these interventions evidence based, and should we be prescribing them?
I My hope is that absolutely they're going to start paying more and more attention. I refuse to wait for enough harm to be done that there's court cases to demonstrate it. That's too late. There are patients and children and adolescents and young adults being harmed right now, and so it is up to us to continue to um, make things more clear, present things in multiple ways. At the end of the day, also, it's the physicians responsibility to know what studies are out there. So it's one thing for, let's say, mainstream media or op-eds to push back on the CAS review or the HHS, and that's one thing. But for physicians to ignore um, peer-reviewed, excellent, comprehensive, systematic reviews of all of the evidence out there for this model, that's they're ignoring the harm that's being done. And so again, there's a difference between someone's opinion, whether it's, politically or socially, versus what the data shows. We don't get to ignore data, whether we like the data or not.
And I echo that, and I do think what, again, I keep going back to the opioid situation as a touchstone, but when I mean it's important because medical legally it's important. I think when it was really bad before it declined, I was like, oh my God, all these people writing these prescriptions are going to get their butts sued. And I do feel that this paper even though we voice frustrations about how the whole system seems to be geared the other direction, this is a very important paper for medical legal moving forward, because again, like, I document things like, oh hey, there's controversy in this area because here's a bunch of, I do that type of documentation. This would be something that would come up and say, hey, look, here's a review that collated and brought together all of these issues. And doctor, were you aware of that? Did you warn your patients of that? And I'll bet you 100,000 million% that they don't write that in their documentation. They might just say, oh, everything's fine, I told them the issues. And so I think it's important for that specificity moving forward for medical legal cases, because unfortunately it's really gotten into that realm where that is needed to put the discipline in, as well as these other policy reforms we were discussing, like for prescription drug monitoring. This is more evidence. Hey, you know what? There's a rationale to have a policy on this. And so I think that's why, my colleagues, they did such a great job working on So I do think it's real important. And I do think the tide is turning.
One thing that
Uh-huh.
I'd like to say is that, I mean, it is conceivable that some people will say, fine, these risks are there, we'll still want to take it. But for medical associations, for someone like the Endocrine Society to look at this compilation and say we're going to disregard it, I don't. I mean, I, obviously, Dr. Mendoza has much more uh, experience here. I don't see how that happens. I mean, if you are going to come out with a guidelines that are, based on evidence, here is the evidence of harm. I mean, look at that and then issue your guidelines, um, you know, in light of that evidence. So I remember back in 2023, May 2023, when I had just started to started reading these papers and understanding them. Fortunately, they were quite easy to understand. The stats level is pretty basic, and there's not much beyond that in many of them. I actually wrote an email to the authors of the Endocrine Society Guidelines of 2017, asking them that these are some of the evidence of harm that I had found, and I linked to them and said, are you working on a revision of your guidelines? The very next day, the director of clinical practice guidelines of the Endocrine Society, who I had not emailed, she responded back and saying that we are fast tracking a review which updates these guidelines, and nowadays we follow the grade methodology, which was not something that we did before. In fact, I later found out she had written a paper asking the clinical practice guidelines to follow the more stringent methodology. And she CC'd it to the chief medical officer of the Endocrine Society, and then another person who serves on many Endocrine Society guidelines committees. So she responded back this very next day, which was very encouraging, telling me that they're working on it. So that review has not come out, and when our paper finally got published, I emailed her back again, letting her know that this paper is out there, and you can read all about it, um, and that there is no evidence of benefits either. That email has not been responded to, but it is there with them, with her. So I hope they respond sometime to say, okay, this is what we think about it. Maybe just to tell us that we were wrong, and if we were, that's fine. I mean, that's how knowledge progresses. But they have to respond. I hope.
I mean, I don't think they will because it's a medical legal issue and they don't, that's just how I feel about it. I mean, I hate to, some people might know this, but I hate to break it to everyone, but the American Medical Association was behind making pain, the quote unquote fifth vital sign and tying quality metrics and reimbursements to, yeah. And they never said a peep during all the overdoses. And then they just, you know, now we're all about responsible prescribing. So I think that there's a complex relationship with the medical societies and the actual practice of medicine. I think there's recognition that it's highly politicized, and again, I think a lot of these prescribers are going to get caught in the medical legal um, boomerang that's going to happen. Um, but I think there's probably some levers again at the federal level or they can pull in terms of the funding of these societies. The AMA really, it's not about physicians being members. They make their money from the billing code system. So, I mean, I think that, I have a friend who, someone I know is works at the AMA, and she says that they'll have trans-identified doctors stand up at meetings and just cry if their hormones got taken away, they're going to kill themselves. They like say this, in a public setting at the AMA at levels where they're, so I guess I'm mentioning that because I think that the societies are in their own echo chamber. And again, that's why I think, I mean, Lauren has seen this so much with, obviously with psychiatric and psychology associations. Emergency medicine really hasn't commented so much on this, but during the opioid epidemic, they were speaking out. But it didn't seem that our voice, it couldn't overcome the regulations related to pain. So I hear you. It matters, but I think that these institutions are captured, like we've seen, sort of parallel with education and whatnot. So I don't know, Lauren, if you have
Well,
other things to say
sure.
on these
And I think just to add
associations.
to that, my stance has been all along, now that we know what we know and we also know what we don't know, I think it's extremely important to speak out, whether you're with an association or you're in private practice or you're working for a hospital, because to remain silent is to be complicit in harming every single one of these patients moving forward. And these are these are people that are in distress. These are patients that they have their whole lives ahead of them, and to not stand up and speak out, um, for the safety of patients and providing better medical care, you're complicit. So I hope that the physicians will hear that. I hope that patients and families out there know and take some hope in knowing that there are doctors and researchers out there fighting for better care. And it's, again, I'm not going to ever stop fighting it because I think patients deserve to be treated with excellent medical care, as well as not be lied to with overselling benefits and underreporting harms and just continuing on a path that's been peddled as life-saving.
And the paper is available open access. We paid the fees. We ourselves paid the fees, and anybody can access it. I mean, they can print it out, take it to their whoever they wanted to take it to.
Yeah, we've posted it in the thread there, and we'll continue to post it in the ask a question. Please stick to the topic, civil. Also, if you're having trouble getting elevated to speaker, please try logging out and then logging back up. About that. Are you able to speak yet?
Yes, I'm able to
There you
speak.
go. Great.
So,
Go right ahead.
okay. My question is about the typology of gender dysphoria. And if doctors and researchers nowadays, there are any nowadays who still believe in it and believe that homosexual males have a different experience of gender issues than heterosexual males, and that should be something that doctors and clinicians ask about.
Okay. Maybe a little bit off topic, but do any of our clinicians want to respond to that question? Do you think that our our clinicians still convinced that this is a thing? I think is
Yeah,
the
the Blanchardian typology, or the notion that homosexual males and heterosexual males have a different experience of gender issues, and that clinicians should ask about that along with other uh, assessment questions.
I can at least speak to,
seems like
yeah, I'm happy to jump in. At least in treating patients comprehensively and treating patients based on their experience, I think and Carrie, you can chime in on this. It's looking at an individual's experience. So anytime someone comes in, it's my job to obviously look at history, medical history, psychiatric history, developmental history, medications, medical care, and everything. But then also talk with the patient about first why they're there and talking with me, and we explore um, the way that they have experienced things, and so that psychotherapeutically we can address it best for that patient.
Yeah, just to echo that,
seems like an
my area of like
individual.
oh, I'm sorry, Lou. My area of care isn't to like, do a comprehensive psychological assessment. I have folks come to the ER with a psychological crisis. I do have a team that's her area of expertise, and I do more the medical clearance. And so yeah, so I don't have more, I just am not at that level. That's not sort of my wheelhouse. But more of the adverse effects and meds and things people are on, and getting my psychiatric team involved to do their thing, because people are sent to the ER if they're suicidal or not functioning, like their psychological distress is so extreme that they're not like functioning and they're a harm to themselves or others.
Okay. Is that looks like the person who had a
Can I ask
question
a
dropped off.
follow-up if that's
Sure.
I'm wondering if this organization um believes in autogynephilia or age.
If Diag
Yeah,
believes in this,
yeah.
um, it's I would say it's not really it's not something that we're focused on. Uh, I would say kind of at all because we're uh, more focused on the whether or not the medical care is ethical as opposed to what the reality of this is. I mean, we think, you know, males are males and females are females, and that there's biological reality, and that the medical pathway is quack medicine. But beyond that, it hasn't been relevant to to the work that we do. Um, how I would leave that um, to the psychiatric or psychological professionals who are working with these patients. We're not a medical group, so yeah. Okay, we have another question from Julie Ray Goldstein. You can now speak. Go ahead, Julie.
Yeah, so my question is specifically regarding since this is, I assume a lot of this concern is due to preventive care and possible side effects, and actually looking at the full medical history of a person rather than just a black and white male versus female. So my question, and obviously, Dr. Mendoza, you work more in emergency medicine, not necessarily as a primary care physician, but based on that, if let's say you have a trans woman who's been on estrogen for quite a long time, over 40, would part of your recommendations of preventive care be yearly or bi-yearly, every 2-year mammograms?
So yeah, I don't do primary care, but I definitely always talk with patients and put in my discharge instructions things that they need to follow up with if they haven't, like if someone hasn't, they have, I'm just giving an example, like a GI bleed issue, but it's not something that needs to be admitted, but they haven't had a colonoscopy. I would definitely be giving a referral to GI and putting that in my discharge. I would say that my documentation is around just communicating adverse effects, and there really isn't an accepted standard of screening in these populations, which is part of what I think we were trying to get at with her and visibility around these issues. So I would definitely do tell people that they should speak with their prescribing physicians about what the appropriate screenings would be, because I am concerned that they could be at higher risk for different cancers. So I say that and I document because medical legally, one of the things doctors, I don't do it just because I don't want to get sued, but it's that failure to diagnose is one of the medical legal planks, and failure to tell people to follow up is that's unethical. So I don't know if I exactly answered your question. There is a specific aren't specific protocols out there, but I would definitely be raising any things I feel that should be followed up from a safety standpoint. Whether the patient does that, obviously patient compliance and just insurance. So many issues prevent patients from following up if they really want to, but my obligation is to be the guardian of their health and mention those things. Did that answer your question?
Well, let's go back, because if I'm reading it correctly, you do agree that the incidences of breast cancer among transgender women on HRT are much higher than cisgender men, correct?
There's increased cancer risk. The exact detail around it, I can't say is known of certainty, but it is an increased risk. So I do feel that an ethical doctor would mention that. But I don't do
Of breast cancer specifically.
primary
The risk of breast
care. I
cancer goes up dramatically, but I think as far as the data goes, it shows that it is a little less than natal women, uh, but but it goes up dramatically compared to male.
Yeah,
Exactly. And
but
my point being, what would preventive care for a population at risk of breast cancer be?
Well, I just think overall part of this conversation is there needs to be, again, rooted in reality. So cancer screenings should be part of it, as well as that then insurance needs to pay for it. So just my neck of the woods is obviously not primary care. So it's my neck of the woods is related to saying, I see this as risk, please follow up, and give them as many of the resources to follow up. Now, whether they could get you know, um, the screening covered, because it's a very complicated landscape with insurance, just for anybody. I don't know. But for me, I just will tell you it's more about identifying the risk and giving them the best tools I can to follow up. Does that make sense?
so I'm afraid that we have a hard stop at 6 o'clock Pacific. So I'm here, but I think the key is, is that now that this paper to their clinicians and Okay, great. So I think the paper is out. This can be used by patients, and patients can work with their physicians to try and mitigate these risks, try and find the best preventative care, screenings, whatever is relevant to getting quality medical care. A lot of what the problem is that this isn't quality medical care. It's not evidence based, and these health risks are serious. So hopefully, this paper will help clinicians and patients, parents, anybody who's in this world. Um, so a big thank you to our guests, Dr. Lauren Schwartz, Dr. Carrie Mendoza, and M. Lal. Um, Thank you for joining us. I know it's short notice and after your paper was published. If you haven't already done so, please join DIAC by clicking the join button at diac.org. That's di-ag.org. Our power to reach our lawmakers is through our numbers. It's important to show that we are a silent majority who believe in classical liberal principles, following the science, including on the reality of sex, ethical evidence-based medicine for all, the power of civil discourse and opening for the rights of women and girls, for sex-based spaces, honors and opportunities, LGBT rights, and the necessity of a compassionate, reality-based society where truth matters. Thank you all for joining us.